It's my pleasure now to introduce our next keynote speaker, Dr. Jocelyn Elders, who was the 15th U.S. Surgeon General and the first African American female to hold that position. Dr. Elders is the eldest of 8 children. She never saw a physician until she went to college. At age 15, she got a scholarship from the United Methodist Church and went to the Philander Smith College. She graduated there at age 18 and entered the U.S. Army as a first lieutenant. In her time in the service, she was trained as a physical therapist. Dr. Elders attended the University of Arkansas Medical School on the GI Bill. She did her internship, her residency in pediatrics, and her fellowship in endocrinology at the University of Minnesota. In 1978, she joined the faculty at the University of Arkansas Medical Center, and she did a lot of work on growth of children and treatment of hormone-related illness. In 1987, she became the director of the Arkansas Department of Health. She was nominated by President Clinton in 1993 and was sworn in as the 15th Surgeon General. She focused on prevention and care for the poor and the powerless. She is now a distinguished professor of public health at the University of Arkansas School of Public Health and a distinguished professor at the Clinton School of Public Policy. She's received numerous awards, both regionally and nationally, too many to list here today, but her bio is in your packet. I hope you will join me in giving a warm welcome to Dr. Jocelyn Elders.
Thank you. Certainly want to thank Karen for that wonderful introduction. And I especially want to thank the University of Missouri and their health policy, and I realized it was 2 of you that went together to put this on, but for inviting me to be a part of your 12th annual Health Policy Summit. I think it's wonderful that you are having these summits, and from the things I've heard this morning, I certainly feel that you were reaching and touching on the things that were critically important and that we need to be doing. I know that for the past week we've all been I'll say public health has been in crisis mode. We've all been concerned about, certainly as we should be, about Ebola. But you know, if we had put more emphasis on public health all the time, as we're putting on now, I think we would not have as much fear. The reason we have so much fear often is because our people are not educated, or as educated as they should be, on how to take care of themselves. We think very often, you know, we can look and we criticize the doctors that sent the patient home from Texas Presbyterian. I would have been, not knowing the history, not knowing what I know, I wouldn't do it today. But at that time, I might have done the same thing. And, you know, the fact that the nurse didn't stress that he was from West Africa, you know, so we can all be critics in retrospect. And our Congress, you know, it's wonderful you're having this policy meeting because our Congress, we haven't confirmed the Surgeon General. And we're talking about appointing an Ebola czar. So I'm just saying that we'd had a Surgeon General, well, we wouldn't have to be taking our director of the CDC, turning him into the Surgeon General. And he's done a wonderful job, and so is Dr. Fauci, and everybody, as far as I'm concerned, has done a wonderful job. But I think we sometimes react to the wrong things, and I think you are the new transformational leaders of healthcare and healthcare reform You will be the people that will really make the real difference as we begin to move forward in this new era of what's going on. And from the conversations I've heard, I realize you're doing that. Why would I have a bridge? Of course, you have bridges too. You bridge in the gap. But, I think that when we in healthcare, we're going to have to bridge the gap between what's going on in health and healthcare reform and make a difference. We're going to bridge the gap between our sick care system and our healthcare system. One of the things when you build a bridge, health engineers know three things. One, this bridge has got to be able to take what we call the dead load. It's got to be able to support itself. And when we talk about supporting itself in healthcare, we're talking we've got to have medical schools, hospitals, we've got to have educated populace. All of that is a part of the dead load that's out there, because if you don't have any doctors, you can't talk about treating. You don't have public health personnel, you can't do what you need to do. They've got to be able to support the live load. This bridge has got to be able to support what you want it to do every day. If you want bicycles only to go over this bridge, it doesn't have to have as much structure. But if it's got to take over the 18-wheelers, we've got to have a bridge that can support the 18-wheelers. And lastly, this bridge must be able to support what we call the storm load. In the past week or 2 weeks, we've been dealing with the storm load, and that's Ebola, and we have to know how to do that. So as you think as the new health care engineers for health for the 21st century, we have to think of where we are, what we're wanting to do, what we're trying to get done, and make sure that as we build our bridge that connect from point A to point B, that the bridge we build can take care of the live load, the dead load, the live load, as well as the storm load. You can no longer sit here in Missouri and say, well, we don't have to worry about what's going on down in Arkansas or what's going on down in Texas. And we certainly don't have to worry about what's going on in West Africa, but you do. So we are becoming global engineers as we move forward and do the things we know we've got to do. We've got to transform our present sick care system into a health care system. We've got the best doctors, the best nurses, cutting-edge research, the best hospitals in the world. But I want you to know that we do not have, we all know, the best health. We are not the healthiest country in the world. When the World Health Organization start looking at the health of our nation, I'm afraid we aren't first, second, or third. Or we can say, well, maybe we aren't spending enough money. We spend more money than anybody in the world on health care, and we can't brag about having the best health. Our infant mortality, I used to say, when people say, oh, why is the black infant mortality so high? Well, of course, we realized that we had far more premature babies, but the black women had far more premature babies, and we still don't know why they have far more premature babies. We know the higher your prematurity, the higher your infant mortality is going to be. But our infant mortality has come down drastically, and I want you to know I'm thrilled about that. But we still are far too high, and our black infant mortality is higher than any of the industrialized countries. But the Hispanic infant mortality is not nearly so high, so I have to give up on myself. Oh, well, it's just because they're poor, because it's more than that, and so we have to keep working to try and find out why. One of the things we know if we don't change our direction, there's an old ancient Chinese proverb, so if you don't change your direction, you'll end up where you're headed. And so I think that there is no question that that's some of what's going on with us. We all know our vision for the 21st century. Everybody in here, and you've seen this lots of places, but we want healthy people in healthy communities. You can't have a healthy community if everybody in your community is sick. So we've got to keep the people healthy. We've got to have a health care system. It's got to be available. It's got to be affordable, accessible to the people that are there, and it's got to be crisis responsive. We saw a lot of cracks in our system recently, but I think that's good. At least they're cracks we can fix. It has to be patient-centered. You know, our healthcare system is, for the most part, in the past, I don't know about in Missouri, but I do know, it's not patient-centered, it's physician-centered. And so we've got to move, and we're moving away from that. Our patients are really becoming very empowered patients. And we've got to recognize that, and that's good. It's got to be prevention-focused. We've been spending 3% of our health care dollars on prevention, 97% on care. If we would provide more prevention, we would have as much sick care. So it's got to be purpose-driven and solution-oriented. It's got to foster individual responsibility. We've got to teach our patients to be responsible. And I was very impressed. You know, most of you may, or some of you may or may not know, I was a very strong supporter and proponent of school-based health care, school health education. And I feel that that's when we've got to start. We've been doing too little, too late. We've got to educate people early. We talk about obesity. It's now we're 18% of our adolescents are obese. And 60+% of our children in schools are on school lunch programs. And we don't educate our young people about good nutrition. And we took physical education out of schools, and we feel that they should sit and watch the internet all day and get skinny. Well, I'm living proof that that doesn't happen. I used to be nice and slim when I was down on the farm working from sun up to sundown. But now that I sit around at the desk and twiddle, well, I got wider, but I didn't get taller. We've got to foster individual responsibility. Our young people can't be responsible if we don't teach them how to be responsible. It's got to have human dignity, improve health status, enhance quality of life. Our healthcare system has to be transparent. Most of us know that if we want to go out and buy a car this afternoon, we could find out the price, the color, everything that it has on it, everything. But go to any hospital in this city, maybe the University of Missouri, but I'm not even sure. Well, you can't find, if you had to have your blood pressure taken, you probably couldn't go in and find out what it cost. You know, you have to have an MRI or anything. Most hospitals don't do that. If you want to look at what different doctors in town charge, you can't find out. You can find out a few scattered, but it's not that more and more we're getting where that's going to be available. It's got to be more transparent. We've got to develop a consumer responsive healthcare system for all ages. You've seen these everybody in here know the health goals of the nation. Every 10 years, we set out and get out a new set of health goals of the nation. Now we're in 2020, and we all know, we had 2010, 1990. We've had them. Every 10 years, we work toward them. We've not gotten there, but we all say we want to people to live long, healthier lives, but we don't do the things that will cause them to do that. We said we want to have health equity and eliminate disparities. We've been saying that ever since we started, and nobody in this room feels we have no disparities. We want to create a social and physical environment that promotes good health. The reason why why we have 2 healthcare professionals that have Ebola is because of their environment that they were working in. They were working in a healthcare environment. Out of the people that have died in West Africa, 30 to 40% of them have been healthcare workers. And we understand that. They're the first people to see the patients. So that becomes a workplace problem. And we want to promote quality of life, healthy development, and healthy behaviors across all lifespans. Healthcare has gotten to be such that it's the largest item in our budget. We're up to about $3 trillion now. We have 318 million people. 5%, that's only 5% of the world population, and we spend far more dollars. Yet, we were at 21.3% of our people age 18 to 64 didn't have health insurance. Now in November, I think, or earlier, it was down to 16%, and now it's down to 13.7%, and that's because of the accountable health care. And we've all complained about it. We all don't like it, but we've been trying for over 100 years in America to get health care reform, and we're just getting there. And so, listen, let's not worry about throwing it out. Let's fix it. Everything else we get and we don't like, we fix it. So I think what we need to do is think about how we can fix it. We don't have enough doctors, and we don't have enough students entering medical school. Everybody comes on to get health care. Prescription drugs have gone up from $3 billion in 1960 to over $262 billion in 2010. We have fewer solo practitioners, more people in group practices, and we all know that we have inadequate preventive health care, and our medical education needs to be reformed. We've trained in our doctors for 20th century health care, and we've got to train our doctors for the things that they're having to see each and every day. We've got to train them that shot they give won't fix everything. We've got to deal with the social determinants of health and all that are out there. We've got to deal with the disparities, and we know that we don't have many acute diseases anymore. We have all those chronic diseases with old people like me. We end up, we've got diabetes, we've got arthritis, so all of the things that are going on and the things that are costing our healthcare system and your emergency the most are the people with trimorbidities. These are the people that come into your emergency room over and over and over again who have mental health problems, who have diabetes or some other type of chronic disease, and substance abuse. You see them over and over again, many times. So we've got to deal with those. So if we think for just a second about what this affordable health care means to us, we still have millions of people who are uninsured and don't have access to health care. But we have millions of people who've been insured, and that's good. We can't deny people because based on pre-existing conditions. Sometimes people are saying, well, they've been in the hospital with breast cancer and they're getting treated, and they come in to tell them their insurance has been canceled. So we don't have to, so that we can't do that anymore. Prevention and wellness is promoted, and we've got to make sure that it's used. We've got to capitalize on that section of our healthcare. But in the past, nobody talked about that. Children can remain on their parents' health policy until they're 26. Well, so in the past, many of the children that we're talking about, their parents didn't even have health insurance. And yet we know, so I think it's very good. It takes most of them now, they're about 26 before they get out of college. Well, maybe not your children, but a lot of the children, they go and they have to, I tell everybody, I paid for the same 12 hours for my son to graduate. He was a senior. He dropped them all. All of them. So I don't think my children were the worst children in the world, but I'm still trying to find out how you get rid of them. We have competition that's induced into the insurance marketplace. Everybody's out there competing now. We're giving tax credits to small businesses so that they can get health insurance. The way we were before, if somebody who owned the company, if they had health insurance and they were old and had cancer or had some other chronic disease, they couldn't afford to have health insurance and offer it to their employees. And we certainly began to subsidize low-income families. And I realize that Missouri is not signing on or involved with the Medicaid expansion, but Arkansas did get the Medicaid expansion. So far, we like it. Well, we are a small state, and we've had lots of people who have been able to get insurance that was not able to get insurance before. But see, our poverty level, the only thing we increased, really expanded Medicaid for, was for pregnant women. I said, if you're pregnant, you can get Medicaid up. We went up to 180+%, 85% of poverty. I said, but if I break my leg, I can't, I can't get insurance, and not everybody was like that. But I think the pregnancy, and that was a good thing. That's part of the reason we aren't spending so much money on neonatal intensive care nurseries, because many of our women got prenatal care. But we can get it from our employees, Medicaid expansion. We mentioned our parents staying on our parents, and the marketplace, and of course direct enrollment. Looking at our population data, we've already mentioned this. There's 7.3 billion people in the world in 2014, and 5% are Americans. Our senior citizens are we're getting older. Proud about that. And 17% are Hispanic, 13% African Americans. And so we're having more and more, we're the most diverse country in the world. But we've got to learn how to live with our diversity. A lot of diverse groups are affected by health disparities, ethnic groups, language. If you can't understand your patient and the patient can't understand you, they can't do what you say. You can be down, tell them all you want to, but if they can't understand you, they can't do what you say. And we talk about neighborhoods. If you can't teach what you don't know, and you can't lead where you won't go. So if you don't ever go out and see where some of these people are living and coming from, you really don't understand it. And we all understand the rest, but let me just say a bit about education. I think that we need to have, everybody in here knows that that there's a direct correlation between health and education. And that we've got to educate our people, and we need to start early. I feel that we need to have early childhood education. Children are half as tall as they'll ever be by the time they're 3. They know half as much as they will ever know by the time they're 4. Hope, will, and drive has been determined by the time they're 5. And let's say that if we ignore them until they get 5 and they come in and join with everybody else to compete, they're behind, they stay behind, and they never catch up. So we need to make real investments in getting children a good start. The other thing we've got to do is we've got to make sure we have comprehensive health education in our schools from kindergarten through 12th grade. You've got to educate our people on how to be healthy. And if we don't do that, there's no way we can keep them healthy. You can't educate people who are not healthy, and you certainly can't keep them healthy if they're not educated. You can't keep ignorant people healthy. So we need to know that. So we need to have our schools, we need to partner with schools so that we can keep people healthy and reduce the cost of health care costs and begin to make some real differences. We all know the major problems of our health care system. It's access, cost too much and deliver too little, and quality. And we do not have the same quality throughout. Many of our rural areas don't have the same kind of quality that you have here in Columbia. And that's true all over. So we've got to do a better job. When we have disparities in quality of health care, we have disparities because of problems related to the system. Sometimes we have a system and we give patients handouts to read, and they can't read. So I tell everybody, the obstetricians treated my patients, everybody, just like they did me. But when they handed me a folder to read, I would usually sit down and read it. But if you've got a teenager who may or may not be able to read, or she'd throw it away and never read a line of it. So we have to make sure the material is appropriate for who we're handing it to. We have problems related to the provider. And we mentioned the language barrier, the cultural differences of people, religious differences. And a lot of people mistrust the Western medicine. We have certainly problems related to the patient. And we talked about education, socioeconomic status, and cultural competency. When we look at the social determinants framework, we think of the social policies and the economic policies. And in this square box are some of the social determinants. Healthcare really makes up a very small percent of why people are sick. Just the act of providing health care. Education is very critical. Housing. If you live in poor, lead-infested, roach-infested housing, you have a far more greater likelihood of being sick. If you work in a physical environment, a work environment, it predisposes to your having problems. We all know that rich people have better health than poor people. And there's a direct correlation between income and health. Transportation. Sometimes people don't even know how to use transportation. And of course, all of our isms, all those isms we walk around on our back, racism, sexism, classism, all of that. Problems with our criminal justice system. And of course, we've all been reading about the problems you've been experiencing. It's just that yours made TV, and ours is still under the wagon. So, but it's still out there. And of course, our social concerns, and probably our genetics, except what our behaviors, does not have as near greater influence on our health as our genetics does, and our local community. The major determinants of health is our social and behavioral factors make up 50%. Our environment, 20%. Our genetics, 20%, and access to care, only 10%. So we can fix access to care totally. But access to care, when you talk about health, you have to talk about your physical health, your mental health, your environmental health, all of the sexual health, all of those are part of being healthy. And any one of them can fail. I think we've already talked about all of these: poverty, lack of education, risky behaviors. You've worked hard. You've markedly reduced tobacco use, but we still have 21% of our population still use tobacco. Many of our teenagers are still drinking and still using drugs. We still have too many car crashes. For a while we were working real hard on reducing car crashes, viewing public health. You told the car industry, so you've got to make a safer car. And heavens, now they got so many buttons and whistles on the car until I don't even, we don't even, but they're safety features, but we said they had to have those. We went to the highway department, the transportation department, so you've got to build safer highways. And so we made a great big impression on reducing highway problems. And so those are all things, so all of those factors very much influence our health and what goes on about it. 9 truths about our health care in America. I've told you we spend more money than anybody else. I have a shorter lifespan, not healthier, and a higher infant mortality rate. Smoking's on the decline, and we've gotten fat. That's because, we aren't exercising as much. They took exercise out of schools, and if children don't learn to exercise by the time they're 10, many of them will never really take on this as a real issue and that they have to do. And we've known this. I know we knew it 25 years ago. They did a huge study, and they showed that. But, we don't use that kind of data. We just say, oh, well. We found that diabetes has increased almost a third since 1990. And that's because I've gotten wider. We've had marked improvement in preventable causes of death, like high blood pressure. And that's good, because more people are taking their medications, and more people are trying to control their blood pressure. We're eating less salt. We're doing a lot of the things we know how to do. And we have a lack of access to care for all. We've made progress, but not enough. And we have a lack of health literacy. We've talked about our aging population, and our fastest growing segment is greater than 65, and I mentioned how good that was. But I like that. Increasing numbers of minorities by 2050, 50% of our country will probably be minorities. Of the children born will be minorities, and of course, the health equities. I hit the wrong button. Former Surgeon General David Satcher said that his colleagues in 2002, which is some time ago, and it has not gotten better, calculated that 83,570 African Americans died who would not have died in 2002 if black-white differences in health care did not exist. That's a rate of 229 excessive deaths per day. And that's the equivalent of a Boeing 767 being shot out of the sky and killing everybody on board every day, 365 days out of the year. Now, we don't feel that that's tolerable, so there's something, and that's something we can do something about. The burdens of disease are increasing. We have a widening of the gap between rich and poor, increased incidence of chronic disease, and healthcare cost has gone up from 5% of our GDP in 1960 to 18% and scheduled to be 20% by 2020. Our over age 85 population is increasing. What are the cost drivers? well, I mentioned me getting old, perversely incentive caregivers and performance data. You know, we have some not all of our caregivers are truly honest, above board, and everything they do is for the right thing, and you know, the idea is money. There aren't many of those, but the ones that do make millions, billions. Inefficient, uncoordinated, unlinked care. We have better technology, and that's wonderful. Better treatments, better drugs. Not all of the drugs that are out there that's proposed to be better by the pharmaceutical company are any better than the old drugs we had all the time. A lot of them are, but we have better new science. And we're going to have a real worker shortage to take care of all the people we need. If we look at our healthcare workforce, the largest healthcare workforce is our patients. And we've got to educate our patients so they can help take care of themselves. And if we don't, we aren't going to be able to provide all the care we need. We've got to we heard about the community health workers. We've got to use different kinds of healthcare workers to be able to get some of the things done that we need done. What are some of the issues that we have on the horizon related to health care? We mentioned issues related to access. We've talked about provider access, financial access, cultural and transportation access. Issues related to education. Issues related to poverty. Issues related to social and behavioral factors. Issues related to sexuality. You know, do any of you know how many hours the average for all the medical schools, all 126 medical schools, the average number of hours spent on sexuality education spent in medical school in 4 years? 5 hours. We spent 5 hours talking about sexuality issues in medical school, and it's 36% of healthcare dollars for women of reproductive age, and globally, for all, it's 18% of the global cost of health care, and we spend 5 hours. So we've got to do better than that. So our medical system is best suited for diseases of the past, not those of the present or the future, and we need innovations in medical education. We've got to re-educate. Well, we've got to redo our system and educate our doctors. We're a health illiterate society. I already told you that people can't learn if they're not healthy, and they can't stay healthy if they're not educated. We've got to teach good health to children in schools, on TV, online, books. We've got to prevent science-based answers and protect people and arm them with correct information. And we've got a lot of myths and other kinds of information out there. And I just told you, sexual and reproductive health problems account for 18% of the total global burden of disease and 32% of the burden among reproductive age women. We're not a sexually healthy nation. We had our teenage pregnancy, I want to tell you, has gone down, and I'm proud about that. I'm proud of all the work you've done. We had the highest teenage pregnancy birth rate in the industrialized world, and we still do. But it's been reduced 56%. That's real. We've gone from the average number of children born to teenagers, we've gone down from 67 per thousand down to 27 per thousand. So we're talking about teenagers, so I'm thrilled about that, and we should all be proud that that's happened. Our HIV cases are down even more. We have 1.3 million people living with HIV, and we're down to about 37,000 new HIV cases diagnosed every year. Now we've got better, more effective tests. We can diagnose them within hours rather than used to take a week or two. but we feel that we don't tell our young people and don't want to tell our people about using latex condoms. And when I used to talk about condoms all the time, they said, Dr. Elders, condoms will break. I said, that's right, condoms will break. But always remember that the vows of abstinence break far more easily than does latex condoms. So, as you can see, this was from the Guttmacher Institute for 2010, and you can see what's happened to the pregnancy rate, the top line, the birth rate, and the abortion rate. Everybody says, well, we have more abortions. Well, that's not true at all. Our teenagers are really, they didn't learn from us. They've learned from books, TV, other things, and they are taking better care of themselves. So, in fact, it's been shown that teenagers do a far better job than we old folks do when they start looking at AIDS. I've already told you, we've gone from 12% of our population being fat to 34% being fat, and 67% of us are overweight. Thank you. Mental health. We hadn't been paying for mental health. Our many insurances didn't pay for mental health, and the mental health makes up 15% of our burden of disease. 50% began before age 14, and 90% are treated if they get in early enough. But we keep seeing them in our emergency rooms over and over and over again. Well, what are some of the strategies we can do to begin to deal with some of these? And all of you know all of these. We've talked about, we've got to educate our people. We've got to educate. We've got to have access strategies where we're improving that. We've got to have prevention strategies. You've done a good job on preventing teenage pregnancies. Hopefully we are going to prevent and stop Ebola in its tracks. We've got to have strategies of compassion, continuing to do good high-level research. We've got to have some political strategies. You've got to go educate our politicians so they are not out there not doing what they should do. So we, as individuals, may have to take on a politician. And I said one of the things that I learned that you have to realize that you have to educate your politicians because they really don't know, and you have to go talk with them all the time, keep them up to date. Whenever anything new comes out, go to them and take it to them so they'll know, and have whoever you pick for what you're going to change be the go-to person. Everybody comes through because they'll have a stack of papers that high on their desk, and they read the slips. I said, make sure that you read it, break it down, and have it at a 6th grade level. Not that they need 6th grade, but you've got to have it so they can look at it quick, get the summary, and make sure it's true and accurate. So that's really critical. We've got to have some leadership strategies. The 5 C's of leadership are, and we in this next century, or in this century, we've got to make sure we've got to have clarity of vision. Know what it is we want, know what we want to get done, and know how we're going to do it. And we need to have that before we go in because I can tell you, our politicians are very smart, they're very clever, and they can talk you out of what you thought you wanted to say. And before, you've got to be consistent. You've got to have consistency, and you've got to be competent to get the job done. You've got to be committed. You have to give your time, your talent, and your treasures. We have to, we wonder why is it that every criminal has a constitutional right to a lawyer, but we don't feel that every baby has a right to a doctor. That's because the lawyers did a lot more arm twisting and donated to a lot more PACs. So we as doctors we've got to do a better job. And we've got to make sure we have control. I think that it's good that somebody, in public health is trying to convince our politicians that we don't need to be closing borders and electing Ebola czars. So, yeah, that's not the best public health in the world. That Jocelyn Elders said that, so I don't know whether I might not be right, but I do think I am. So what's your role? What are you going to do? You're out there on the front lines. You've got to listen to what your people say they need. Learn what they want, so you can lead them to where they need to go. So you've got to listen, learn, and lead. You've got to be aware of the problems, advocates for the problems, and develop an action plan that works in your community. You've got to make sure that we deliver state-of-the-art health care. Our health care is still 19th century. We've got to at least get it up to 20th century and make it sure we finally get it to 21st century delivery. We've got the best doctors, nurses, research, but we're still carrying our delivery system on a wagon. We've got to make sure we deliver value-based health care. You know, so much of health care we do is how many patients you saw, or how many tests you did, not how much good did you do. We've got to be the voice and vision for the poor and the powerless. And see, in healthcare, public health, nobody ever worried about all those things we prevented. You know, they're talking about 10,000 patients with Ebola at the end of the week. But we don't think about that. We've got to have some outcome measures, and we've got to be open. We've got to take every opportunity we get. Always remember that opportunities are like a single strand of hair on a bald-headed man. It only goes around once, and we've got to grab it when it's there. The transformational leaders of the 21st century have to be able to do at least three things. They've got to be able to use data, they've got to convene, they've got to be able to communicate, and they've got to learn collaborate with all the different entities that are out there. And we've got to be accountable. For the C in advocacy really realize that life's changing. Everything's changing. Life's about change. And we've got to grow. So life is about change. Growth is optional. We have to choose wisely. And I want you to know, the people in this room, you make a difference. The most powerful 10 two-letter words in the English language is, if it is to be, it's up to me. And you have to feel that you are going to be the people that's going to change our society, make a difference, and you're going to be the transformational leaders that convert us from a sick care system to a health care system. And we're about getting it done. And I'll tell you, like my bishop told me, he says, Dr. Elders, you have to always remember that in the job you're in is like dancing with a bear. He said, when you're dancing with a bear, you can't get tired and sit down. You have to wait until the bear gets tired, and then you sit down. Thank you very much.
Yeah, we do have a few minutes for questions.
Yes, sir.
Chief Paul.
Yeah, I just wanted to tell you thank you, Dr. Elders. My first time seeing you was at Southern Illinois University of Edwardsville, and I was a lot younger.
So was I, and less crippled. See, I could have jumped up on the stage then.
You were the Surgeon General at it's tough. It's tough when you're a minority in this field. And I wasn't sure that I wanted to keep going. And your speech and your talk afterwards and your compassion and your caring, and, you know, a lot of times you get African Americans in a position, but they don't remember where they come from. And they don't give back. So you're in Missouri, and I just happen to be over minority health in the state, and I would not be in my position if you hadn't inspired me. So, you know, to see you fighting today and saying what you're saying today, I love you, and I'm so thankful to you to keep doing what you're doing. I hope I can just, you know, be anywhere near like you. But I just wanted to thank you and welcome you to the state. Thank you for coming to our state, and just thank you so much.
Thank you. One of the things you have to remember, that when you climb the ladder of success and get to the top, you have to send the ladder back down for the rest of it. Thank you very much for having me.